and welcome back to Coffee Break Science, the podcast that brings powerful patient stories to the intersection of inspiring research happening at the University of Cambridge and beyond. Sponsored by the NIHR BRC Devices and Advanced Therapies theme. Today, we're going to delve into the realm of regulatory T cells, the immune system's immunosuppressive powerhouse. These are cells that control and regulate unwanted inflammatory responses to things that our body should not be responding to. In a recent paper published in Nature Medicine by researchers at the University of Cambridge, the role of low-dose administration of interleukin-2, a cytokine that induces the expansion of these powerhouse Treg cells, was found to reduce the inflammation in patients with acute coronary syndrome who are known to have a reduced Treg cell portfolio. This was aimed to enable Treg cell expansion while preserving an active immune system and therefore preventing opportunistic infections. Tune in to learn all about the IVORY trial as well as a patient perspective who was involved in the trial. Hello and welcome back to Coffee Break Science. Today I'm delighted to be joined by Dr. Rouchelle Srinanjan-Rothwell, who is an NIHR clinical lecturer in cardiology at the University of Cambridge. Her clinical subspecialty is interventional cardiology, and she graduated with a distinction in medicine from the University of Bristol. And during her NIHR ACF in cardiology, she completed an MPhil in translational medicine and therapeutics at the University of Cambridge. She was a Fulbright Scholar at Harvard University, completed her PhD in 2024 at the University of Cambridge too, where she studied at Clare College. Her PhD work was presented at the Late Breaking Science category at ESC 2024, and she's super passionate about PPIE and her work has been featured on the BBC, so I'm really thrilled to have you here. Her current research program aims to examine novel anti-inflammatory therapies in the context of atherosclerosis through phase 2 and 3 clinical trials. And she also employs experimental medicine approaches such as the use of imaging biomarkers and immunophenotyping in the context of these trials. Welcome to the podcast.
Thank you, Azin. It's a pleasure to be here.
So, can you maybe start by setting the scene for us as to how you ended up with cardiology?
So my route to cardiology hasn't been, I don't think, a conventional route. So I kind of didn't start off with, I always want to be a cardiologist right from the outset. I kind of, in medical school and kind of beyond, during the first 2 years, which is called foundation years, kind of knew what I didn't want to do more than what I actually really wanted to pursue as a specialty. So what happened after my foundation years was that I was slightly kind of exhausted and burnt out. I had finished my MRCP and I worked really hard to get that, immediately after my foundation years, which is unusual. So I decided to take a career break at that point and go back to Sri Lanka, where I'm from originally, and essentially spent a year doing wildlife photography, going around the jungles of Sri Lanka. And after about a year, I was kind of like, okay, I'm ready to come back now into clinical medicine. But the problem is you can't just slot right back in. I had missed the application deadline to start kind of the second step, which is back in the day, it was called core medical training. So I was kind of randomly looking for opportunities to do research and so I was looking at things. Howard were offering a kind of research fellowship, and there were a number of things, and something related to the heart, which is kind of using nanomaterials to deliver drugs. Sounded interesting. So I was like, okay, let's go for that. And then obviously that had a cardiology angle on it, and other things as well. And then my CV just looked very good for cardiology. And then when I came back, I was like, you know what, I enjoy it. And the other thing about cardiology, especially intervention, is very acute. So you kind of see your patients and then they go home, rather than chronic conditions, which is sort of where you look after them for a number of years and it's usually not curative. So that appealed to me, and it's procedural as well. So you get instant gratification when you unblock a blood vessel, little things like that. And it's a younger group of patients that you treat when, for heart attacks and things, generally speaking. So those were the kind of motivations to pick cardiology, but I think I almost sort of stumbled upon it because I took a career break.
Super cool. You've done so much. It's amazing.
Yeah, that's very kind to say.
So I'm really surprised, actually. I don't know very much about the heart. My career has only focused on oncology, and I think the heart is the one organ that does not get cancer, if I remember
It's
correctly.
rarely,
Very rare.
Yeah.
So I didn't quite realize that heart attacks affected younger people, generally speaking. Do you see it more often in certain populations of people over others? Is there a genetic factor?
Yes, 100%. Yes to all of those questions, really. The other thing to say is, in my world, young is sort of below 80 is young.
Okay.
So, I mean, however, in that spectrum of, people who present with heart attacks, there are people who present in their 30s to 40s. The majority present in their kind of late 50s, 60s. Now, risk factors certainly play into it, especially for those who get their heart attacks younger. Almost all the patients sort of who are kind of below 40, I'd say, were smokers. In my practice, at least, there's obviously hereditary genetic issues like familial cholesterolemia, and they're very prone to getting gunk building up in their arteries and everywhere. So that's strokes and heart attacks. And there's also hypertension, the traditional risk factors, which play into kind of one getting plaque buildup in the blood vessels. But increasingly, we're kind of recognizing inflammation and the immune system, which kind of brings all those risk factors together, and that's what actually propagates this plaque buildup into kind of a person eventually having a heart attack. So yes, in terms of risk factors, there's traditional ones and more kind of swanky risk factors that are coming up now that are increasingly being recognized. And if you have those or multiple risk factors, you have a tendency to get heart attacks at a younger age. Yeah.
So that leads us really nicely onto pathogenesis of ischemic heart disease. Can you outline how, on a kind of molecular functional level, like what is happening in the body to induce this condition in people?
Yeah. So I'm going to keep it really short, to be honest. If I had to give you a one-liner, I would say, kind of putting all the current evidence together, is essentially a lipid-driven kind of inflammatory condition. Now, obviously, traditional risk factors such as, hypertension, obesity, family, genetic risk, all play into this. And what happens is, when you have the trigger with the risk factors, you get build-up of essentially kind of lipids in media of the blood vessel, which is there are different layers in one of the layers in the blood vessel, basically. And the entire process is orchestrated by immune cells. So from kind of eating the lipids, and then the lipids kind of accumulating. I mean, they actually accumulate in macrophages, which are a type of immune cell, and then they die, which form the necrotic core of these plaques. And then, so that's kind of how the gunk builds up. I mean, I've oversimplified this a lot, but I think, it's a bit boring to talk about the molecular mechanisms.
It's not boring at all.
And then, so that kind of leads to, over years, you can get build-up. But there are also other triggers that can cause the build-up to then rupture or burst. And then what happens is you get kind of your body is always trying to heal, essentially. So it tries to seal the rupture of this plaque with essentially blood clots, and then that actually ends up blocking the whole vessel, and then you get, the more serious and life-threatening heart attacks, essentially.
I see. Thank you for outlining that. Macrophages seem to be the underlying culprits for a lot of things, so it's really interesting. I saw that you recently published your work in Nature Medicine, so congratulations for that. Super cool. And I think this was mostly around the findings of the IVORY trial, which demonstrated safe, low-dose IL-2 use for patients with high risk of major adverse cardiovascular events. So what does this mean in practice for patients who are at high risk?
Okay, so that's actually a perfect summary. I should start using that. But essentially, yeah, so the rationale behind the trial was that there are some people who are at increased risk of having second heart attacks or strokes because they have grumbling inflammation. Now, that sometimes people have that even before they have a heart attack, but in some people, it's sort of triggered after a heart attack because your body reacts to this insult to the body. Currently, there's no treatment to actually mitigate the inflammation to reduce this risk of having future events. And low-dose interleukin-2, essentially what it does is increases a protective immune cell called regulatory T cells. Tregs are amazing. I love Tregs because they're just like, they immunomodulate without immunosuppression, which is very, very impressive. And obviously the Nobel Prize went to, the discovery of Tregs last year. So what we found is that people who've had heart attacks or have angina have low levels of Tregs. And what we thought is, okay, let's increase that and see if that can, take the inflammatory trigger away. Now, in kind of drug discovery, there's always the first two phases is kind of proof of principle. Is the drug sort of doing what you want it to do? So the first thing we have to show is, of course, it's safe. So the phase kind of 1B, which is a LILACs trial, was giving tiny little doses to patients who had angina and heart attacks and checking, is it safe, essentially. And we also measured in that trial if the Tregs went up in these patients when we gave the drug. So the answer to both of those kind of questions was yes. It was safe and the Tregs increased, and they increased in a dose-dependent manner, which is very nice. Mm-hmm. Now, the current clinical useful interleukin-2 is that it actually activates T effector cells at very high doses in metastatic renal cancer and multiple myeloma. But in very low doses, because Tregs have a very high affinity IL-2 receptor, they don't need a lot, and you can selectively activate Tregs without activating anything, the other effector cells, which we don't want to do. So essentially, low-dose interleukin-2 increases Tregs, and so that was already we found that out. We decided to pick a nice dose which was safe and really well tolerated by the patients, and took it into IVORY. And in IVORY, we gave the drug for a longer period, so for 8 weeks. And what we were looking for is we did scans to actually see, okay, so we know that, the drug increases Tregs, but does it actually reduce inflammation in the blood vessel? So that was what IVORY was looking at.
And how did you measure the inflammation to see whether it was reducing it?
Yeah, so inflammation is measured using PET-CT. Now, Cambridge is super lucky because we have Professor James Rudd, who's sort of a pioneer in FDG for kind of vascular quantification of inflammation. And I've worked with him for a long time, from the time I was an ACF to now clinical lecturer. So it was really lovely to, and I was really lucky to be able to do a PhD in what I've been, was dabbling in for quite a few years. So we used FDG PET-CT essentially.
Okay, wow. And when you chose interleukin-2 as your target before the phase 1B of the trial, did you use animal models or cell line models or both before? Or was it just that it was already really obvious in the literature?
Yeah, so low-dose IL-2 and the Treg story, basically, it's been going on for some time, right? And they've been trying to use Tregs in autoimmune diseases to sort of dampen down the immune system, because usually it's, immunosuppressants, which is obviously has side effects and things. So low-dose IL-2 has been used in autoimmune conditions, but never in kind of ischemic heart disease. So we were the first to use it in ischemic heart disease. So it had been used, so it wasn't first in human. It had been used before in other conditions. It was the first time we used it in heart disease, essentially.
Okay, cool. So interesting. It seems that a lot of the time these innovations come from what is kind of already present within the system. It just needs a bit of a amplification.
One of the main things about the trial is IVORY was sort of special in a couple of ways in terms of experimental medicine. One is that it used a repurposed drug. So in drug discovery, like the cost is so much, like millions and billions, if you start at basic, molecular level, preclinical, and take it. So if you can take something that's halfway there and kind of apply it to a disease, that's a win-win. So we repurposed the drug. And then the other thing is, so in cardiology, it's not like other diseases where you're looking for symptoms to improve. You're looking for events, which are deaths or strokes. But events are really rare, and you have to wait a long time for these events. It's not like, yes, my back pain got better or my migraines got better. That can happen in 2 weeks' time after a drug. So in cardiology, we have this problem for especially like, ischemic heart disease, where you have to do, and if you're looking for events, because they're rare, you need like thousands, tens of thousands of patients, really. So what we do with these scans, they're called imaging biomarkers. And especially for FDG, what we've shown is, okay, people who have high FDG uptake and inflammation in their blood vessels are more at risk of having events. And that's been shown with population studies and things. So we can then kind of reverse that and say, okay, so these guys have inflammation. If we give the drug, it reduces inflammation. So maybe then it can reduce events. So we don't have to kind of, before spending, millions of pounds or dollars on doing a trial with kind of looking for events, you can do one with imaging just to give you an early signal of clinical efficacy.
Yeah, that makes a lot of sense. And what about in, for example, postmenopausal women who I believe actually the greater reason of death for many women post-menopause is heart disease or heart attacks rather than like cancer or anything like that.
Yeah.
So do you think this low-dose IL-2 is safe, and do you think it's reasonable to give it to women who are postmenopausal just at low dose to reduce their risk of heart attacks? Or
you mean as a preventative therapy?
Yeah.
So yes, it's safe in women. The women and cardiovascular disease is a whole topic that's come to the forefront for a number of reasons. One of which is that actually it is the biggest killer in women, not cancers. So, but we always we don't really clock that, I don't think. And actually, if you look at kind of the global burden in women, death due to heart problems and the burden's actually increasing, whereas overall in the world it's decreasing. So that we are missing a trick there. And the other thing with women is women's risk of kind of cardiovascular and ischemic heart disease is actually lower before menopause to men. And there's that trigger where we know it, we see it, and it goes, we then reach it becomes equal to men. And we've actually, on that front, I'll come back to your answer, we've just got funding to study heart disease in women called She Heals. It's a 10 million grant to look at how heart, blood vessels, how the gunk builds up in blood vessels after menopause, and how we can maybe start preventative therapy like lipid-lowering therapy for these women earlier than we do normally. Because traditional risk scores, which we use to prescribe these medications, don't actually capture menopause separately. There are no female-specific risk factors captured in these risk scores. So we'll be working on that, and that'll be a separate project, which might be a nice, good separate podcast, because I think it's just so needed, and it's going to be a huge collaboration across the world. Now, in terms of low-dose IL-2, it could be, but the problem is it's very expensive. So, what we're trying to even to get the statin prescribed, which is, totally proven, very cheap, it's a battle. So IL-2 is like far, 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 far away, essentially. But the other thing is there's obviously primary prevention and secondary prevention. So we've looked at secondary prevention. So you have your first event, and then we're going to stop the second ones. Primary prevention, we haven't done the trial yet. And I'm looking at that for we're setting that one up next, basically. So that's in people who haven't had any events. we're trying to see, does that still reduce inflammation? Do they even have enough inflammation that it needs reducing, that it needs a special drug, for example, So that's to look at, yeah.
Okay, super cool. I'm really excited to see where the She Heals trial
Oh,
goes.
it is. I'm just so happy about it. Cambridge are leading on it. So now, yeah, we should talk about it separately because it's so exciting.
Yeah, I'll definitely follow up on that. Today I'm joined by Mark Andrew, who is a patient who participated in the IVORY trial that Dr. Srinanjan spoke to us about earlier. He is from Fulbourn, Cambridgeshire, and actually also works for the university. In August 2022, Mark had a heart attack while cycling home from the gym, and despite being active, healthy, and having no history of heart problems, tests at Addenbrooke's Hospital confirmed that he was having a heart attack. He was rapidly transferred to the Royal Papworth, where a stent was fitted to hold open a narrowed artery, and this restored blood flow to his heart. While still in hospital, Mark was invited to participate in the IVORY trial. And I'm really grateful for Mark for agreeing to come and share his story with us in some more detail.
Thank you, I'm pleased to be here.
So to start with, can you tell us a bit about, in as little or as much detail as you're comfortable sharing, how has this event, this huge life-changing event in August 2022, how has it affected your life?
Firstly, I would like to say I'll be eternally grateful to all the people who did save my life on that fateful day. And yes, it has changed my life in some ways, perhaps not as far as I might expect. I live what I would describe as a completely normal life now, except for making a few adjustments and being on some medication for life. It certainly has made me focus on my own health in several ways. I do continue to exercise regularly. I do circuit training, weight training. I don't do any running anymore. I used to be a runner, but I find I get out of breath, so I knock the running on the head. I monitor my blood pressure and my pulse quite closely. Never used to do that before. I eat more healthily. I'm on a low-carb diet, low sugar, low salt, and the result has been quite good weight loss, 10% of body weight in a year, which I'm quite happy with. I cook using fresh ingredients, generally try and have a healthier lifestyle wherever possible, active as well. One negative thing that's happened to me is the cost of travel insurance has more than doubled. I don't feel I'm a bigger risk, but the insurance companies kind of stick that on quite heavy, I think. I value support and seeing my family and friends far greater than I did before. I realise that life is not forever, and it's not been my first brush being close to death. When I was much younger, I had an allergic reaction and was admitted for a night in Addenbrooke's with anaphylactic shock.
Oh my goodness.
2 episodes is quite enough. I don't want a third one.
Okay, thank you so much for sharing. The lifestyle changes that you have started to make, like the change in diet, for example, is that something that your cardiologists are supporting you with, or are you kind of just doing that yourself, just through your own efforts?
Cardiologists and more the occupational therapists at Addenbrooke's were the initial instigators of it. I had already started a low-carb, low-sugar because of my partner. She was diagnosed as type 2 diabetic before that, so we kind of were eating a bit healthily already, but that was only a couple of years earlier. As I say, the damage I think I did to my heart was probably in my 20s and 30s because I didn't care what I ate or drank.
Okay, thank you for the honesty. So we mentioned that you were invited to take part in the IVORY trial after your stent fitting at the Royal Papworth Hospital. I guess you won't know whether you had the placebo or the low dose interleukin-2 drug that they tested in the trial. But what was your experience firstly being in the trial, and also how was the drug administration? Because from what I understand, it was subcutaneous administration over 8 weeks. Were you working more flexibly, or were you on leave from work, or what was your experience like during that process?
The overall experience was very positive. I was mostly on sick leave for the first, I think, about 4 or 5 weeks. So it was having the time was no particular problem, and I don't live too far away from Addenbrooke, so it was not too difficult to get there. The actual experience, I don't know, by the way, I don't know whether I had placebo or the actual drug, so they never tell you. I've got a feeling because of the end result, and I'll come on to that in a bit, that I may have had the actual drug, but can't be certain. I have no problem with needles, so having the injections was easy for me. It's a series of injections daily for a week around the belly button area, and then in the same area weekly for the next 6 or 7 weeks. It didn't hurt at all. The worst thing was all the waiting around. There were blood tests before and after the injection. So
Every day? Or just the weekly?
Each visit.
Oh, wow.
So the trial team had an arrangement with the blood lab, so they were able to fast track it. But even with the fast tracking, there were still hours spent lying on a bed just waiting for blood results to come back from the lab. But you could read a book, watch the TV, use the internet, so it wasn't so bad. I found that I benefited from all the additional tests and extra information. I knew nothing about my condition before it happened, and I felt that I learnt a lot more from being on the trial than if I hadn't been on the trial about how to handle it and why it happened in the first place. Basically, build up cholesterol in the arteries. Bits come off sometimes, get lodged where they shouldn't, and you get a blockage, and there you go. You start to have a heart attack, possibly. So I learnt a lot, and I was able to digest that and take it all in, and like a sponge I soaked it all up. The extra diagnosis were ultrasound scans, CT scans, PET scans. I'm also pleased that the small part I played in the trial was able to potentially help lots of other people afterwards.
Yeah, absolutely. So going back to your kind of surgical experience and the stent fitting at Royal Papworth, how was the recovery process for that? And do you still get regular checkups and follow-ups, or do they kind of leave you to your own devices and you just kind of only go back to hospital to see your doctors if there's any discomfort or you're worried about something? I
found the actual procedure and initial recovery in Papworth a little traumatic because you're awake the whole time. Whilst they're fitting the stent.
No way.
So you're continuing to have that heart attack, although you've got some medication in you initially, some injections, some painkillers, but you're actually watching it on the screen. They have an X-ray style screen where you actually, it's fascinating.
So they can't put you to sleep?
Well, they could if you're very distressed, but I wasn't so distressed. I mean, I was awake throughout the whole thing. I had no particular pain either.
Okay.
And I've since spoken to a relative who went through the same thing after me, and he confirmed the same thing, that he was awake and watched it on the screen.
Goodness.
So the first 24 hours really was, I just felt incredibly tired. Really, really couldn't hardly move. Just lay there on a bed, just completely tired. Difficult to sleep because you're wired up to lots of sensors and machines bleeping around you all the time. So that first night was probably the worst, and then it gradually got better. I mean, they discharged me after 3 nights there.
Okay.
And then I went home feeling tired, and you just start your recovery. Really, when you get home, you're encouraged to go for a very tiny walk. Just increase that daily, maybe if it's just a few meters, and gradually build it up. Oh. As time went on, you just feel better and better. And I was also lucky to have signed up for the cardio rehab, which is like a small gym inside of Addenbrooke's, and they coax you back to fitness. Amazing. Very gently and monitor you. So tons of monitoring. So I was doing the cardio rehab and the IVORY trial at the same time, and I think that really helped me. The end result for me at the end, the final scans of the trial after it came back with the results, that my heart had actually repaired itself in excess of what would normally be expected from an event like that. So, and the doctors were really happy with that result. So if they were happy, I'm happy.
Yeah, amazing. How long was the surgery then? How long were you watching that?
Oh, I would say it took about, it's difficult to tell because I didn't time it, but I think it took about 20 to 25 minutes.
It's quick, fairly quick. I thought it would be Oh, interesting.
About that, yeah. I mean,
Okay.
the procedure is that I have the stent, which is a small, very small, millimeters long, kind of balloon, inserted. I had it inserted into my wrist and pushed up to the right artery on the left-hand side of the heart. If that doesn't work, they have to go in through the groin area instead, but they managed to get them in through the arm, in my case.
Amazing.
And you just see it and hear it happening, where the doctors, the surgeons are talking around you. Slightly out of it on morphine, so I don't remember it too clearly, but I remember it clearly enough to know what was going on. So it was a strange, surreal experience. Don't want to repeat it, because I was short of breath and anxious. And when the balloon is expanded inside the heart, you actually feel a relief. You start to breathe more easily.
Oh, wow.
And at that point, my goodness, they just saved my life, because that's the moment.
What a moment. I mean, yeah, even with whatever medication they gave you, for pain relief, I can just try to imagine what that relief must have felt like. That's incredible. And what an amazing outcome as well for you, for the heart to have recovered, more than what would have been expected. And you're saying now that you have a more or less normal life, even if it means that you had to give up running. Are you now back at the gym and doing weightlifting and all the training you were doing before?
Yeah, more if anything. I'm doing 4 classes a week.
Wow.
And occasionally cycle to and from work.
Amazing.
Yeah, I'm feeling well.
It's amazing that they can do it minimally invasively, I guess, through...
Indeed, yeah. There was no need for major surgery, so that was great. Really, just a small incision through the wrist, which healed in a matter of days. So that my as I say, my first effect was just feeling so tired.
And now that you've returned to more or less the normality of life, what is the message that you would like to leave our listeners with? My message for the listeners is, if you can spare the time and any risk you perceive is acceptable to you, take part in the trial. But if nothing else, you'll learn more about what your condition is during that trial, and you've got the doctors and nurses' ears when in times when you wouldn't have. You get to spend a lot of time with them, and so you can learn lots. Amazing. And make further adjustments if you're able to do so. Thank you so much, Mark, for your time. That was really insightful. I had no idea about the way that a stent is fitted, first and foremost, and also how great the recovery can be with just fitting this tiny little thing to expand the artery. It's incredible. And thank you for sharing your insights from the IVORY trial as well. And I wish you all the best. You're welcome. Thank you. So with that then, what do you most look forward to in your field of cardiovascular research, whether that's in your own work or just in the field in general? I think because I'm a clinician scientist, I think I'm really sort of lucky in Cambridge, because you have the strength of the place you're in, which excites you about what you can do for the future. And then there's also the field itself, which has exciting questions that need to be answered. So I think for me, from kind of a Cambridge perspective and what I've had the privilege of doing, I can't wait to use kind of imaging biomarkers in other disease processes that are cardiovascular, as well as, there's things like microvascular angina, MINOCA, like, those they're acronyms, but they're kind of like different causes of, it's not only gunk building up that can cause heart attacks or angina. There are other things, and our knowledge of understanding of lots of different types of things that cause heart attacks and angina, apart from ischemic heart disease, is actually not very advanced. So using imaging biomarkers to explore those, and immunophenotyping as well. So that's really exciting. And then the other thing that excites me in the field, in my clinical practice, is there's also so much scope now in terms of stenting to apply technology to detect plaque or build-up that is more likely to cause problems. So we used to historically think the narrower it is, those are the things to stent. But now increasingly you can have a blood vessel that's not narrow, but it's sort of grumbling, waiting to, with a little bit of build-up,
But that actually causes a heart attack, not the other one, which is sort of quite narrow, but it's actually quite stable. So, there's so much going on. So you have cameras you can put into the blood vessel and image. Yeah, it's pretty cool.
Wow, like an endoscope, but for a blood vessel.
Yeah, and it's like an ultrasound, intravascular ultrasound. So we use that, and that technology is kind of improving. So when we put in stents, we put that in to check we've done it as well as we can, basically.
So is that over the skin, or do you have to go?
Yeah, so interventional cardiology is minimally invasive. So we go through the wrist, essentially. If we can't go through the wrist, 95% of the time we go through the wrist. And we put catheters all the way near the heart, and then inside the catheter, we thread a wire, and through the wire, we deliver our cameras and our stents and things. It's pretty cool, actually. I love what I do. I love kind of even the research stuff as well as the clinical side. It is, being an interventional cardiologist and an academic is hard work, like doing 200% jobs. Interventional cardiology is very, it's like surgery, it's procedure-based, so you have to put in a lot of work. I used to say it's like doing the extreme sport version of academic medicine, to do like a procedure-based specialty and still do academia, because both of them are really, I think, to do it well, it's really hard work.
I can only imagine, because just as an academic, like I'm just a postdoc, but even that job
You're
is
not
like
just
all
a postdoc. It's hard. But
I don't have patients to look after, or I don't have that
Yeah.
aspect of things. So I have so much respect for, all academics, but specifically clinician scientists. I think it's amazing. We've seen the effect that it's already had on your patients, and the way you speak about your research is just really beautiful.
Yeah, I love what I do. There's no question about it. But the work-life balance does take a hit. I'm not going to even, pretend like it doesn't. Even last year, I was pregnant last year with my first baby. I was labelled a geriatric mom or pregnant person, but it required lots of scans, all of that, and then you're still in the cath lab doing procedures, wearing lead aprons, which, you're not forced to do anything, which I wanted to do. But, what I find with the clinical stuff is I almost find that like a breather from the academic stuff, because you do your session and you clock out most of the time. But with the academia, I was doing grant writing till like 10 o'clock at night, so it's you're stenting in the morning, and then you're writing, and it's, you've done it as well. So it's very intense, right? Mm-hmm. And obviously the trial's ongoing, so you're trying to sort all of that out as well. Yeah, so I do question my life choices on it used to be a weekly basis, but now that's sort of, yeah.
And then you made time for this as well, so thank you so much.
No, I think it's important. I think you're doing a great job with this podcast, because that, you bring experiences and kind of its knowledge as well, and in inspiration, like somebody might hear it and think, oh, maybe we should use low-dose interleukin too.
yeah, definitely. And congratulations on your baby. That's
Thank
so exciting. Are there any last messages that you want to leave the listeners with before we wrap up?
Just one thing to say is that what I didn't realize, and it's just a message, if you are kind of in a state where doing a clinical PhD is quite hard, because or any PhD, I guess, nothing ever goes to your timeline, really. And I used to be and obviously COVID came along when I did this trial, and you wouldn't believe the problems that crop up. You can't even, I could make a cartoon series, like a mini series of the things that happened. We nearly ran out of the drug because there was a supply issue, then the scanners had to be changed, then so many little things that delay, and you kind of feel like, oh my God, am I ever going to finish this? But something that I think is really important that got me through it is having somebody I could talk to, and that was actually James Rudd, who was he was my mentor, and I could just go there and say, I'm really scared that I'm going to do all this work, and at the end of it, I'm not going to have a PhD, because because at that point with COVID, you didn't know when that was going to end, and you were like, am I going to just what am I going to do? So And he was really good, and I think that's just the value of that was just immeasurable, really, like how much you just need somebody to just keep you, let's just get through this bit and then we'll reassess again if things haven't improved. So I think that's my one piece of advice, is to try and find that person for you, because that makes a huge difference. Yeah.
Definitely. Thank you so much, Rochelle, for your
You're
time.
very welcome.
It was really...
Thank you for having me.
Yeah, it was lovely to listen to you, and I've personally learned so much about cardiovascular disease, and yeah, super inspiring to have you here.